I knew when we scheduled today that it would be a bad week. I have to apologize on behalf of our dean, who's very, very sorry not to be here today. But this is a week where the World Health Assembly is assembling, where the Geneva Health Forum is foruming, and where the general practitioners are also holding their congress in a different city. So many people will be watching us online on the recording. And this means only the most dedicated people are here for the live Q&A. It is my greatest pleasure, despite all this, it is my greatest pleasure to introduce Professor Emanuel. As you will have read, he's currently the Vice Provost for Global Initiatives and Co-Director of the Health Transformation Institute at the University of Pennsylvania. From January 2009 to January 2011, he was a special advisor for health policy at the White House under the Obama administration. And until 2011, he was the director of the Department of Bioethics at the NIH, where yours truly arrived straight out of residency to learn bioethics on September 10th of 2001. Zeke has taught me most of what I know about being a bioethicist. He's also the guy who told me that media training was mandatory because one day journalists would call and I would need it. Little did I know. Today, Professor Emanuel will speak to us about the US healthcare system, one of the largest patients in the world, at the bedside of which you spent more time than most physicians over the course of your career. And today, of course, many of us are worried about what your current president is doing to this patient, to its patients, and to the science on which it's supposed to rely. But this patient was not altogether well even before that. We're also worried in Switzerland about our own health system because these days it's under more pressure and undergoing potentially more changes than it had received in a long time now. So we're also interested in what you have to say about the US for reasons of similarities between our systems. I look forward to hearing you very much and also to the discussion that will follow. The floor is yours. Thank you for being there.
Thank you. We're a small enough group. Don't hesitate to interrupt if I say something that isn't clear. I'm going to begin with a short rendition of what Trump is doing to the American healthcare system, not to the global healthcare system. And then then I'm going to get into deeper structural issues that afflict the US healthcare system, and to a lesser extent, I think, the Swiss system. But some of them are common and some of them are less common. I would argue that there are 5 goals of any modern healthcare system of an advanced industrial economy. One is universal coverage. A second is reasonable costs. At this point, I would argue that that's no growth in spending as a percent of GDP. Consistently high quality of care. Fourth is equity. That means that access to care actually is consistent across race, sex, geography. We know that in every country, rural people do less well than urban people, mainly because of access issues. And then high satisfaction by physicians, patients, and others within the healthcare system. Is the American healthcare system achieving these goals? Well, I would argue that there's no plausible path to universal coverage in the United States. We have now 7.7% of the population uninsured, and it is inevitably going up. And I'll give you 2 reasons. One is Trump wants to cut back on funding for parts of the American healthcare system. And the other is that some of the supplements we put in place because of COVID are going to expire, and that expiration will cut back a lot of people who get coverage. They won't buy as much. It's estimated, the most recent estimates is that the number of uninsured will go up over 13 million people. So increase of 50% of the number of uninsured. Our national health expenditures hit $4.9 trillion in 2023. That makes the United States healthcare system the third largest economy in the world. Our healthcare is bigger, yes, bigger than the German economy. Just American healthcare, bigger than the entire GDP of Germany, bigger than the entire GDP of Japan, India. Only the US and China are bigger. That gives you a sense for how broken the system is. Here's our annual insurance coverage. For a family of four, it's over $25,000. Let me, again, just put that into context for you. The median household income, so 50% of the population above, 50% below, is about a little under $80,000. So roughly a third of the median household income health insurance covers. It's insane. There's a huge amount of debt, and there's no plan even to keep healthcare at 17.5% of the GDP, which is what it's been for the last 15 years. And we have no success in healthcare quality. I would just say we all should realize that whatever the flaws, that this is a quote of a prominent CEO, American healthcare system is the best in the world. After all, if you get sick, there's no better place in the world you would want to be treated than the United States. He actually was the CEO of one of the biggest pharma companies in the US, and we were at a cocktail party, and he said this to me, and I almost fainted because it's a ridiculous claim. It is true that the United States is arguably the best in the world when it comes to cancer care. So if you look at this data comes from the 2018 publication of something called the Concord Research Trial, which looked at millions of people across countries and looked at the 5-year cancer survival of those people. And you can see the United States in almost every category. If we're not the best, we're in the top 5. And there are very few cancers where we're not leading. Some of these statistics, even though they're done in the same way, et cetera, are not quite believable. That Jordan, for example, or Cyprus has the best colon cancer, just not believable. But, you know, whether it's colon cancer or breast cancer or other cancers, we really are the world's, I think it is fair to say, no place you'd prefer to be, and for many reasons, the United States may be the place you would want to be treated. After that, I don't think it's a plausible argument. Hypertension, we have half of all adults, 120 million Americans, have high blood pressure, but less than 25% of them have it well controlled. Diabetes, 38 million Americans, that's about 10% of the entire population, have type 2 diabetes. Only 22% of them have it under control, where in this case, under control is there are 5 things you're supposed to do in managing: have a low hemoglobin A1C, have high blood pressure under control, have cholesterol under control, get an eye exam every year for retinopathy, and get a foot exam to make sure that there's no infections that aren't being treated. Even if you only look at the 3 lab tests, hemoglobin A1C, cholesterol, and blood pressure, right? Only 22% of people with diabetes get that done annually. Terrible quality. Infant mortality, our infant mortality rate is 3 times higher than the countries that you know, just not high quality in any stretch of the imagination. Even among rich white women, it's not world-beating. And then maternal mortality, our maternal mortality rate is 10 times higher than other countries that have focused on this: Netherlands, Japan, Norway, which have the lowest maternal mortality in the world. I should say, we know we can do better in all of these categories. Let me just give you 2 examples. In hypertension, we have what we call hypertension champions. We've identified hundreds of practices all the way up to health systems that can get to 80% control. Beyond 80% is actually hard. There are a lot of people who have very resistant hypertension. But it's not hard to get to 80%. There are a few things you have to do. Give people a blood pressure cuff, take it rapidly, get them on multiple medications, use some combination pills. Everyone does the exact same process. It's not complicated. We just don't do it. On maternal mortality, we also know we can drop it substantially. California undertook, get the data from every hospital, make hospitals undergo, just like we test for resuscitation in a hospital and make sure everyone's in practice, you do the same thing for mothers who are bleeding. You can do the same process to evaluate how you're taking care of people with preeclampsia and things like that. And we can bring the maternal mortality rate, it's in California, it comes down to comparable levels in Western Europe. All right, and then there's satisfaction, right? And I like to say, I only have to say 2 words in the United States to show you that satisfaction is terrible, and that's Luigi Mangione. When he shot and killed an executive at United Healthcare, people didn't, what is this vigilante justice? That wasn't people's initial reaction. The initial reaction is, Yahoo! They got it. And it just shows you how much people hate the healthcare system. And literally, I was just reading that there was, more healthcare systems are working on preventing violence in the hospital. When I grew up in American healthcare in the 1980s, we had plastered all over hospitals, patient rights, what we have to do to respect patients. Now you have what patients have to do to respect the system, and one of which is, don't start yelling. You yell at a staff member, we're going to remove you, and all sorts of things that patients should not do. Very different change in attitude. And then there's actually polling data. And when the public's polled, you see this, view of U.S. healthcare has declined to a 24-year low. This survey began in 2001, and more people, over 50% of the population, thinks that we need major reform in the United States, and or the system's already in crisis. So not only are we not achieving any of the 5 major goals, I would argue we have no path to achieve even one of them. Forget all 5 at the same time. We can't even get one. We have no plan to get to universal coverage. We have no plan to reduce our costs. We have no plan to have consistent high quality, on and on and on. Okay, that's the problem. What's Trump doing about it? He's pushing us in the wrong direction. They're slashing healthcare spending, okay? They've cut from $120 billion. We call this discretionary spending. This is spending not on Medicare, not on Social Security, but NIH, National Science Foundation, the CDC, the FDA. He's slashing that by 1/3. Well, that's only going to make things worse, not better. He is eliminating programs like Head Start, which is actually paid through the health side of things, and other efforts to support early childhood development, which are critical. We know that actually these programs help with education, and better educated people are healthier and lower healthcare costs. They've already begun a massive workforce reduction. They've slashed 20,000, 25% of the staff working at Health and Human Services, preventing programs on gun violence, improver worker safety, sexually transmitted illnesses. They're going to slow down drug approval process. They're going to slow down our monitoring of infectious diseases, et cetera, et cetera. Medicaid cuts. So the budget that Medicaid needs to be approved every year, and the House has voted, the committee responsible, not the full House, has voted cuts of $70 billion a year, which, as I mentioned, estimated to cut about 7.7 million people off insurance. If you add the end of the special subsidies, that's another 6 million, 13.7 million people. He's established a special group called Make America Healthy Again, focusing on childhood chronic conditions and lowering the chronic disease rate. I highly endorse that goal. We have too much chronic illness and we don't focus enough on it. But at the moment, we have no idea what they're doing. They have no idea what they're doing to actually realize these goals. I don't think it's going to work. It's not going to make us healthy. It's going to actually reduce our research, dissolve critical public health infrastructure that prevents illness, and lead to 13 million people more uninsured. All right, he doesn't like the healthcare system, as I've said in other contexts, it's easy to break things. It's much harder to build up a good program that addresses the problems. But the American healthcare system needs to be transformed. It needs fixing. So he's got the right idea. It needs to be fixed. But sloppy reform is not the way to fix the system. All right? To actually fix the system, you need to understand what the fundamental flaws of the system are. How do we get to a system that can't realize those 5 goals? How do we get to a system that doesn't get universal coverage but costs more than any other system in the world? All right, I think that there are 3 problems, and I call them deadly sins. First one is fragmentation of coverage. There is a very interesting study, which you didn't read, unfortunately, because I think it's one of the, it's actually, it hasn't been followed up in the proper way, but it's kind of like the path-breaking insights from behavioral economics that we're not rational, we're not maximizing utility. And this is done by researchers who gave people like you puzzles to solve, challenges, and looked at how you solve them. And what they found out is that people systematically default to searching for additive transformations and consequently overlook ways that you can solve problems by subtracting problems. So you give a conundrum. We need to get more people insured. What do? We add, we don't subtract. So they said defaulting to searches for additive changes may be one reason that people struggle to mitigate overburdened schedules, institutional red tape, and damaging effects on the planet. So we have a built-in default in our brain to actually, when we're given a problem, how do we add something to solve that problem? We don't say, well, is there something we can take away that's inhibiting progress towards a solution? I think this is one of the most brilliant insights, at least for healthcare in America. And I suspect it's true for lots of programs. If you look at governments, they have a problem to solve. What do? They add a program. Here is a list of programs that we have done in the United States since 1946 to try to solve the problem of getting people health coverage and health services. The Hill-Burton Act expanded hospitals. The federal government gave hospitals money to expand, to make the population better. It started out because a third of the soldiers going into World War II were declared physically unfit to be soldiers in America. These are farm kids and kids who just didn't get good health care. And they said after the war, all right, we've won the war. How are we going to make people healthier? And their solution, hospitals. That's a very telling sign. We'll come back to it. And then we didn't want socialized medicine because we were in the Cold War fighting the Russians, right? So we had employer-sponsored insurance, and that took care of people who were working. And then 15 or so years later, we realized, well, there are 2 groups left out, those who are retired and those people who don't have a job or have a job that doesn't give them health insurance. So we added Medicare for the elderly and Medicaid for the poor or people who are working who don't have insurance. Then we figured out that kids, they're not getting coverage when their parents get insurance or are too poor to pay. And so we created what's called CHIP, Children's Health Insurance Program. We created VA coverage for the veterans of wars, TRICARE for the military personnel, the Indian Health Service for our Native American population. I'm not done. Federal Employee Health Benefits, a separate program for the 2 million or so people who work for, and exchanges, right? Part of the Affordable Care Act, which I worked on proudly. We created a whole different system for people to get health insurance who weren't getting health insurance through any of the programs before. Well, creating programs to cover more people. This is the additive bias we all have. You've got a problem, you don't have You know, the elderly who are retired aren't getting insurance. Let's add a program. It's called Medicare, right? You got a bunch of people who are working, who are making money, but can't find insurance that is affordable. Let's add a program called the exchanges. But adding programs creates lots of complexity and tends to perpetuate or even exacerbate some underlying problems. And new programs spawn further problems and issues, creating additional complexity. And complexity creates more complexity as you try to solve problems from the complexity. So incremental solutions add programs to solve a portion of the problem. And we did. Look, we added 25 million people got insurance from the Affordable Care Act. But we also created many more problems. They also create fragmentation. That is, all those different programs, and that creates complexity, not just in covering people, but also in how you pay doctors and hospitals. It creates problems and complexity in how you actually assess whether they're performing quality or not. It adds complexity because now you have a lot more opportunities for waste, fraud, and abuse, and checking that creates complexity. It also adds lots of time and effort, cognitive load on individuals to figure out, how do I get insurance? And actually this leads to non-enrollment. 60% of Americans who don't have insurance are actually eligible for one of those programs. They just can't figure it out. And complexity facilitates system-wide waste. Let me give you one number to illustrate this. The United States spends close to $1 trillion, 20% of all healthcare spending, on administration. That's just insane by any stretch of the imagination. Yeah, 20%. And that's because of all this complexity. Every hospital will have one or more people just billing for the person who's in a bed. So you got 500 beds, you have at least 500 and often 700 people doing the billing just for that person. It's insane. So, confusing enrollment criteria because of the fragmentation and complexity means uninsurance. Choice overload for individual people, actually poor consumer choices. So one of the things I didn't mention is we have hundreds of insurance companies, and for people getting drug coverage in Medicare, we have, on average, each person has 60 plans to choose from. You can show empirically that once you have more than 4 or 5 choices, you make non-optimal choices. Just too many pieces of information you can't. Payment complexity. Each one of these different payers has a different price. So you might have one price for a drug in Switzerland, and my father told me, my father studied medicine here, I didn't mention that. He studied it the other place, Lausanne. But when he first took me to Switzerland in 1971, he said, one of the great things about Switzerland is there's one price. You can go from one end of the country to the other end of the country, one price. It's the same price. I don't know if that's still true. It certainly was true in 71. He showed me, we drove around looking at the same toy over and over again. But not in the United States. We have multiple prices. A different price for people on Medicare, a different price for people on Medicaid, for everything, for the hospital care, for the drugs, for the home services. And billing complexity, as I mentioned, leads to administrative waste and huge pricing. Okay, I'll give you one example, underinsured and double insured. Confusing, misaligned, fragmented coverage leads to underinsurance. There are people who are eligible but don't get insurance. And then there are also people who have double insurance and you're paying twice for them. Insane system. And you know, each part of that is in the United States, nothing's worth millions of dollars in healthcare. It's billions of dollars in healthcare. Fragmentation of coverage leading to fragmentation of payment and fragmentation of quality, which I didn't go into, leading to complexity and very high cost. Problem 2, I call it the great disconnect. There's a mismatch between our health conditions and the design and structure of our healthcare system. The problems we have are not best answered and addressed by the way we've created our healthcare system. When the American booster says we've got the best healthcare system, I know what he has in his mind, right? I don't even have, he's got Penn, Children's Hospital of Philadelphia, where you have the first CRISPR baby, right? He's got Harvard, Hopkins, Stanford, many great institutions. They're impressive, but let me give you a secret. Most Americans aren't treated at these institutions. Even most Americans with really complicated problems aren't treated at these institutions. And these big and impressive academic centers, they're not relevant to most American health problems. Most of our hospitals were initially developed in the 40s, 50s, and 60s. I mentioned that Hill-Burton Act that paid for the development of community hospitals from 1946. The leading cause of death all the way through the 50s up to 1960 were things like diarrhea, tuberculosis, influenza, pneumonia, and trauma. Trauma mostly from cars early on. Just to take one thing, TB didn't drop out of the top 10 causes of death in the United States until 1960, right? So for the first 60 years of the 20th century, it was these acute problems that were being handled. They were best handled in hospitals by specialists. And that's the model, that's the infrastructure we still have today. But the development of medications like diuretics for hypertension, like antibiotics and vaccines have shifted the illnesses we confront. Today, right, 90 cents of every dollar in the American healthcare system, and I am willing to bet in the Swiss healthcare system, goes for chronic illness. Doesn't go for acute illnesses, right? 42% of Americans have 2 or more chronic illnesses. 12% have 5 or more. 85% of adults over 65 have at least one chronic illness. And 90 cents of every healthcare dollar, as I mentioned, goes to chronic illness. 10% go to the stitches, the broken bones on your ski slopes, but minor amount, right? Those problems are not handled best by hospitals. Hospitals are no good at treating diabetes, no good at treating hypertension, which need to be treated every single day. Specialists also are not very good at treating those chronic illnesses. American healthcare system, and by the way, I think this is a problem that probably stretches to every high-income country because we all developed this infrastructure at around about the same time, right? To manage those conditions, you need a lot of primary care doctors who are actually interacting with patients on a regular basis, and you need an infrastructure. You need nurses that can help. You need people who can call the patients to making sure they're adherent to medications. And having so much, and basically 50% of all American spending is in hospitals or specialists, so much of the money tied up in the wrong place prevents you from actually addressing those chronic illnesses effectively. This is where the money goes. 20% to physicians and clinics, and of that, 3/4 go to specialists. 50% or 30% go to hospitals. So you got 45% of spending just in those two categories. Some of the other elements, like some of those prescription drugs, again, for acute illnesses, not chronic conditions. And by the way, we can't change the system really hard. We have specialists who are paid way more than primary care doctors, way more than primary care doctors. Roughly, a primary care doctor in the United States makes between $225,000 and $275,000 a year. And a surgeon, not unlike the Swiss surgeons, cardiac surgeon, neurosurgeon, make at the top end, they make $700,000, $800,000, $1 million a year. That 3 to 4x difference, you don't have to be greedy to say that's a big difference in annual income leading to millions of dollars over a lifetime. If we wanted to change that payment, the physician fee schedule, we call it in the United States, is controlled by the AMA. We have a schedule which is heavily biased to specialists. Each year, the AMA reviews 2% of those fees, but the panel that reviews it, predominantly made up of specialists. Guess what? Guess which codes go higher and which codes don't go higher? I'll leave it to you to imagine what happens. Okay? Deadly sin number 3 is what I call the fraying of the social safety net. This is one of the most important graphics for medical students to learn. Basically, it says, you as a medical student, you're more or less irrelevant to the health outcomes of people. Health and well-being, 30% of it is determined by your genes. Turns out that things like Alzheimer's, right? Not a lot of it is determined by your behavior. There's some. I'm a big believer in the some, but most of it's determined by your genes. And that's true for lots of health care. Individual behaviors, smoking, exercise, how well you eat, your social interactions determine a lot. Social and environmental factors, your income, your education, your housing, your quality of the food you can buy, 20%. Healthcare services, a mere 10%. Well, if 20% is determined by social and environmental factors, right, and you are making people worse in that category, you are going to affect things like average life expectancy. And we in the United States have been doing a great job at undermining our social safety net for the last 40 years, since basically Ronald Reagan. Franklin Roosevelt won the presidency in 1932, promising Americans a New Deal. And his administration did a great job of putting in the Social Security program, workforce programs, union protections that actually did begin to establish a safety net for people. That safety net was augmented in the 1960s, actually in 1 year in the 1960s, 1965, when Lyndon Johnson passed his Great Society programs. Medicare and Medicaid were passed in that year. Head Start was passed in that year. Job Corps, food stamps, aid to primary and secondary schools, all passed in 1 year, and the effect was remarkable. So you can see here, this red line are seniors, people over 65, and you can see in 1959, 35% of seniors were poor, and it plummeted. Why did it plummet? Health insurance. One of the major reasons they were poor was excessively high healthcare costs, and that went down. And you can see it plateaued at the end, the mid to end of the 70s, when healthcare costs really began going up, and other costs. That was the year after the oil crisis, the oil shocks of 1973, and stagflation, and that led to fraying of the safety net. One of our great programs in America for solving poverty is called the EITC, the Employee Earned Income Tax Credit. That's if you work and your income is low from work, the government will top it up to bring you higher income. It is remarkable in getting people out of poverty. You can see that of 31 million people poor, a third of them, roughly, got removed from poverty from EITC, and among children, right, more than a third. It's been a remarkable program for that, and that has actually been one of the reasons that poverty among kids has gone down. But beginning in the 1980s, Ronald Reagan claimed that the problems were exacerbated, not solved by the government, and he began curtailing safety net programs, reduced programs to help poor Americans, limiting food stamps, limiting public housing, other anti-poverty programs. And the reduction in minimum wage relative to inflation, less support for unions, outsourcing of jobs with no benefits, increase in corporate disruption of the food and system, decrease in exercise in school and school programs. And you can see we've not had a real change in our poverty program. Gone up and down, but really no progress, and to some degree worsening of poverty in the United States. These three sins, I think, are the three problems we need to solve if we're going to fix the American healthcare system. Problem one, complexity of coverage leading to lack of universal coverage, dissatisfaction with the system, and more people uninsured. Fragmentation of coverage and payment, and use of hospitals and specialists, exorbitant costs, high administrative costs, and high costs for other things, and a lack of focus on chronic illness. Decline of the safety net, I think one of that issues has led to huge obesity and mental health issues in the United States. What does real transformation look like? Well, I think you actually have to solve each one of these problems. You have to solve fragmentation by a simpler system with more standardization. The great disconnect, we need more team-based primary care to focus on chronic conditions and make the income of primary care doctors much higher. And fraying of the social safety net is we need to actually repair that safety net to guarantee for people housing and food security and basic reasonable income. What does simplification and standardization look like? Well, to resolve the sin of fragmentation, we need to simplify and standardize insurance, quality metrics, and payment. The most impactful way to simplify and standardize American healthcare is to change how we get insurance. So I think we need to make a radical difference. Americans need to get their insurance in only one of two ways. We need to break down all those myriad of problems. You either get it through your employer, which 150, about half the population does, or there's a public insurance exchange, and we can have private insurance companies competing in the exchange, but everyone else who doesn't have employer-sponsored insurance, whether they're elderly or poor, they need to go into this public exchange, and they need to get subsidized to the level of their income so that they can pick one insurance plan, and they shouldn't have 60 to pick from, they should have only 6, a limited number that are manageable. We need, therefore, fewer choices. All the companies have to have the exact same benefits. The pricing has to be the same, and they all have to participate in one billing system. The amount deductibles and copays have to come down and be lower and more predictable. And they have to be the same. Again, none of this variability between plans that makes it very hard to compare. We also need to have standard quality metrics across all patients in all systems, not based upon who your payer is. We need to change how we pay doctors. So primary care, all paid on capitation with large bonuses for quality improvement, and cost control. All procedures, surgeries, whether it's a CABG or neurosurgery, have to be bundled payment with large bonuses for high quality, low surgical site infections, low readmissions, and they have to guarantee at least 90 days after the surgery. Imaging and lab tests are standard payments. We're not having variability. And specialists, this is an area where we don't know how to do it. We need to switch to a value-based payment system. And I will say, literally, in the hour before I was here, I was on the phone talking about establishing a new company to do this kind of thing, because there's not a mechanism, not only not in the United States, but not anywhere. Just to give you an example, this is, I alluded to it. If you are a average person and you're offered 4 health plans to choose from, and you ask people to choose given their health system, only 42% of the time do they actually choose the optimal system. And on average, they make mistakes costing them $200 per month. With 8 health plans, the number of optimal choices goes down to 21%, and the penalty for making bad choices goes up. Okay. Right now, I don't know how you in Switzerland assess the quality of your healthcare system. We measure it wrong. We measure it by asking the payer, whether Medicare or private insurance, to report the quality. That's not where quality happens. Quality happens by the doctor. But the doctor only has a picture, a partial picture of what he or she is doing, because they report different measures to different insurance companies. Just take Medicare. This is the program for people over 65. Has more than 2,200 quality measures. Just think of the complexity, of which 788 are being used in 34 different programs. It makes no sense. Streamlining quality measures would help knowing how doctors perform regardless of who's paying the bill, which is very important. Standardized prices. No individual negotiations between insurers. Standard prices. All plans have to employ the same billing system, so all this administrative nonsense goes away. And because primary care physicians are paid capitation, not so much depends upon exactly ticking the right box. So this, I think, reduces administrative burden of a very complex system and lowers total costs. Focus on treating chronic conditions with team-based primary care. U.S. certainly needs more primary care providers. An emphasis on primary care is the only way to address chronic conditions, and they can more efficiently coordinate long-term care of underlying conditions like hypertension, diabetes, asthma, COPD, and focus on primary and secondary prevention. This isn't going to happen unless we increase the number of primary care doctors. This just gives you a sense for how few primary care doctors we have in the United States compared to specialists. We also have to incentivize this. As I told you, the average primary care doctor, $250,000 to $275,000. By comparison, the average cardiologist, $507,000. Orthopedic surgeons, $573,000. That's worth a lot of money. And it's no wonder that no one goes into primary care. We can concentrate, I would argue, funds for tuition-free medical school towards those people pursuing primary care in underserved specialties. That's one way to do it. Change how we pay doctors so the AMA doesn't control it and we focus on primary care doctors. And then I think team-based care is absolutely critical. You have to coordinate care that includes primary care doctors, nurses, pharmacists, physical therapists, mental health professionals on patients. It reduces duplication, improves oversight, and eases the patient experience. A team-based approach, certainly in the United States, has been shown to prevent hospitalization, improve patient-centered outcomes, and manage chronic illnesses. And they're cost-effective for hypertension, for diabetes, and for many other conditions. All right. The last thing we need to do is focus on people who live the shortest lives. Right now, lots of people are focused on average life expectancy. I think average life expectancy is one of the worst metrics you can imagine. It's an average. And one of the things we know about averages is that they are actually hide the distribution. You could have a narrow distribution around life expectancy or a very wide distribution. All right? We need to identify who those people are. Right now, we don't have a good idea who lives a short life. Much less attention is focused on these health inequalities. But this is a very long list of OECD countries. The highest quintile is the quintile of people, the top 20% of people who die or who live the longest. And you can see down at the bottom, the United States, the top 20% of the population lives to almost 96 years. Switzerland, it's 96.7 years, okay? Japan, which is the outlier, 97.2. Latvia's high at 98.2, right? Turns out that in every country, every rich country, right, those people who live the longest, they live into their 90s. I'm not sure they want to live into their 90s, but they do, right? You look at the second top 20%, and in Switzerland, it's 91.1. So you have 40% of your population will live over 90 years. And the United States is not far behind it, 88.9 years, right? And again, turns out that most countries, it's the top 80s or 90. On the other hand, the lowest quintile, the lowest 20% of the population in the United States is 52 years. That is a 45-year delta. Go to Switzerland, it's 63.7, nothing to cheer about. So you have a lot of people dying young too. Guess what? You don't know who they are, and we don't know who they are. The demographers have not done a good job about trying to identify those people living the shortest. One reason is they have this mindset, it's stochastic, it's just random. Well, I don't think it's random. We could discuss that. Focusing on that bottom, I think, is one of the big challenges, and we don't have a very good mechanism for figuring it out. I think we actually ought to stop reporting life expectancy as a key metric and start reporting what are the bottom 20%, what's their life expectancy. And that will make us begin focusing on that. And we should have a goal of reducing, of raising the life expectancy of the bottom 20% by 10 years. This is what the United States quintiles look like. And you can see the average is low because the bottom 20% is low. The top 80% is actually, top 60% is doing very, very well. And we're not, I mean, ours might be a little wider, the gap might be a little bigger, but it's true in Switzerland, the exact same thing. What are those diseases? This is a preliminary look. I cannot give you a definitive answer, but you can see one of the key issues is diabetes. Another key issue is actually cardiac disease and cardiomyopathies. So those are probably the areas most important. There is some self-harm, but it's actually quite easily drowned out by drug use and cardiac disease. All right. I think the first two solutions that I've mentioned, standardization and simplification, emphasis on primary care, will address a huge disparity, but not everything. We have to repair the frayed social safety net in the United States, and we need to rebuild public support and social programs targeting those people who are at high risk of premature death. All right. I hope I've convinced you that we're not meeting our goals. That's not hard. But I hope I've also tried to convince you that fragmentation, the great disconnect between the diseases people have and the healthcare system, and then the fraying of the social safety net are the three main structural flaws of the American healthcare system. And unless we address them, we have no chance of fixing the 5 major goals and getting to the 5 major goals we want, which is universal coverage, reasonable cost, high quality everywhere, equity across every metric, and especially geography and education, and satisfaction with the system. Thank you.
Thank you very much, Petra Hüppi, a pediatrician. I was just wondering, with your value-based compensation system, to what extent you will prevent complex disorders to be taken care of by the physicians?
Well, it's not like we're getting rid of specialists, right? Look, those complex conditions are, I mean, you can't get rid of cardiologists, you can't get rid of oncologists, but it's not the primary, it should not be the primary focus. The place we're falling down in the United States is not cancer care, for example, which is very complicated, right? It's the basics, hypertension. And so I think we need a shift. That's not to say you're going to get rid of specialists. You're going to reallocate.
Not what I meant. I meant, you know, when you give value to the quality of care that you provide, it will be much easier to treat an easy one disease patient than a multimorbid congenital disorder patient that has many issues, and the quality of your contribution will be more difficult to assess.
Oh.
They could select your patient population.
Yeah, that is true. I don't know that we have any quality metrics for multimorbidity patients anyway. Not now and not in the future. And I don't think we actually have any idea how well we do in care for that. I will say one thing. I don't know about Switzerland, but I think one of the biggest problems on those patients we have in the United States is we're doing better. So they're living longer. So the transition between pediatrician and what happens when they turn 18, 21, 25, terrible care at that transition. Terrible. Because, first of all, most adult docs have no idea, and most pediatricians don't want to treat them when they're 25 or 30. And so That's a whole separate issue. It's an important issue, but it's also a very small, relatively small issue in terms of numbers of the population.
Swiss pediatricians in the room are nodding in agreement with you here. There was another question. Yes.
Thank you. I'd like to come back to the point about complexity and additive bias and the programs you listed. Let me maybe propose two other explanations, and I wonder...
Of complexity?
Yes, of complexity. And I wonder if you agree that they might also play a role. One of them would be some kind of political branding or trying to repackage what already exists to create the impression that we're finally solving the problem. The other one would be discontinuity between successive administrations, right? Administration changes every 4 years, and sometimes the new one has very different ideas compared to the previous one, and that creates discontinuity. So these are the two explanations, and yeah, I wonder, so maybe the upshot is that the problem might be deeper than just explaining politicians their cognitive biases.
Well, I think that there is no doubt that there's a political imperative to say, pound your chest and say, I helped fix the system by adding a program. I can tell you, I've seen this firsthand in politics. We established something called an exchange for small businesses. Every evaluation said, maybe 1 million Americans, 0.3% of the population would get coverage this way. But politicians wanted it because they had been proposing it for a long time. It would boost their popularity with their small businesses in their home district. Is a total waste and hardly ever used now. So I agree there is. But you have to ask yourself, why do we have this incentive to add a program and to pound our chest, we've added something? That's because everyone thinks that the only way you accomplish something is by addition, not that you've actually accomplished the end. We've gotten to universal coverage. So I think it's a bit circular. Yes, there is this tendency for politicians to want, but why do politicians want? Because we all have this tendency that we're only addressing a problem if we add. So I think that's true. There is some back and forth, but the back and forth, I am not sure that the back and forth is the cause of the problem. I think the complexity, once you get different ways of providing insurance, you have different ways of paying, you have different quality, that begins to breed on itself, and you get more complexity. You also get more cheating. Just more, the more complex the system is, the more opportunities to game and to figure out a niche where you can make money. And I think that is really separate from, administrations change, but the bureaucrats who run these programs largely is the same. And I don't think, I think there's a problem there. They're dissociated from the real world. But I don't think the problem is that we've had administrations, at least in the U.S., go wildly from one direction to another. Until really Trump or maybe Bush, we actually had more agreement about these kind of programs and less violent disagreement. Yeah.
Thank you very much. I have a question about something that you haven't mentioned so much yet. I'm an oncologist. So
oncologist?
In oncology, drug pricing is the issue that is discussed. And as we're certainly all aware, in the US, there is no
limit.
Price setting. The sky is the limit. Not to say that here drugs are cheap, but comparatively. So my question is a little bit, where does the making money out of health, actually raise an issue? I mean, you're an ethicist. My question is a little bit, health should be a universal right, no? How can we, by making it a business, actually avoid that there is going to be abuse?
I'll be addressing that on, June 10th, I believe, at the Brochure Institute. Really, this question of right versus people being able to buy is a very complicated issue. Let me say the following. I don't think the mess of the American healthcare system has anything to do with the fact that it's not a right. I think it has to do with structural problems. As a matter of fact, today, almost every American, except for a small, including Republicans, except for a small holdout, actually think healthcare is a right. They just don't know how to realize it because of the complexity of the system. So that's I don't think, I don't like using the rights language, but I don't think most Americans have any problem with the idea that healthcare is a right. And the evidence, I would say, is to expand a part of Medicaid. This is getting into the weeds of the Affordable Care Act. To expand Medicaid, right, states have to adopt it. And a lot of states, Republican states, did not want to expand. The legislatures voted against it. And in many states, citizens forced to put it on the ballot. That, like Switzerland, the citizens would decide this question because it was big enough. It's not possible in every state, but in many states it is. Every single state, every single Republican state in which it's come up, Idaho, Oklahoma, Missouri, Kentucky, that's done this, it's passed. So it's not about Republicans not believing healthcare is a right. The average person believes it's a right. The problem is they can't figure out how to make the system work. That's a different issue. Now, on the oncology drug pricing, that's also a defect. And it's not about the money making, right? I mean, look, food, is it a money-making enterprise? Yes. Do your farmers expect to make money? Yes. Do your grocers expect to make money? Yes. Does that prevent it from being a universal need that everyone has to have? Yeah, no, right? I don't like the for-profit incentive, but I don't think I don't think it's the underlying problem. And I think it's actually distracted us from these other underlying problems. That's the way I would put it.
I'd like to push you on that with a follow-up question. Has there been any data on how much of this very large cost of the healthcare system, what percentage of that is constituted by profits? And is there a similar chart to what you've shown us for life expectancy? Because of course, profit is an incentive. We might not want to get rid of that, but to a point, right? So what is the data on that?
Well, I would tell you, of the top 10 most profitable parts of the American healthcare system, 9 of them are drug companies, okay?
We're not
wait, okay, I don't know of any not-for-profit drug company in the world. I mean, there are some actually, but I think actually, it turns out they're in the United States. Drugs make up about 16%, 1/6 of the American healthcare costs. And the excessive drug pricing would bring down our costs some, but not actually all that much. Because, how do I know this? Drug prices in every other country, everyone thinks they're high, and they're much lower than us. We're not going to get to 12% or 13% of GDP just by cutting drug prices. It's just not. So the for-profit motive, first of all, it's inherent in drug development, I think. It's true in every other place. And I think it's a contributor, but it's not the major contributor of the healthcare problem.
But it's not an either or either. My question was about, is there a way to turn the volume button down?
There's a lot. Look, every academic health center is a not-for-profit. They are some of the most rapacious participants in the healthcare system in America. So I think there's pretty good data actually in the United States that it's not your profit motive. They act the same way. They, not-for-profits try to figure out how they can maximize. They don't call it profit. They call it margin. I think we spent a lot of time on the profit motive. I think it is a problem. Don't get me wrong. But I don't think solving that problem is going to solve the underlying problem of the American healthcare system. It's a structural problem, and the for-profit motive is not a structural problem. You have to deal with people's motivations.
I had another question. I see, yes, Hans, please.
As you know, and as you wrote it, the Swiss system is not as good also. And Switzerland...
Let me just say, I am 100% sure achieved, compared to the US, at least 3 of the goals.
Yes.
You have universal coverage, your costs are way lower than ours, even though they're high, and the Swiss are the most satisfied people in the Western world.
However, access is not very good in Switzerland because the poor people don't have access because they have a co-payment with franchise and payment for the hospital, for instance. And the administration is very bad in Switzerland also.
The what?
The administration, the bureaucracy. So with a friend of mine who is economist, I am a physician, we proposed some reform for the Swiss system, and one of is introduced to a capitation not only to primary care, but to all physicians and and even to the hospitals, for instance. What do you think about that?
So, let me say the following. There are problems of, there are solutions to poor people not having access and dealing with their copays and their deductibles that we can solve, right? You could limit their copays to 1% of income, which they do in Germany. You could limit anyone who has a serious illness like cancer to no copays, which I have proposed, and I think other countries have. It's true in Germany. So I think the poor person access problem is, or at least their payment problem, is easily solved. What do I think of overall capitation and providing budgets? I love the idea of providing budgets. I think the financial responsibility ought to be on the providers. We, through the pen, control 85% of all healthcare costs. Whether we order a test, whether we admit a patient to a hospital, what we also don't write, we control that. And I do think we should actually have more fiscal responsibility on the side of providers. So I'm for hospital budgets. I think it's a challenge. For primary care budgets, I'm not sure you're going to get specialists working on a budget. I think that may turn out to be a structural problem. And also, how you change the budgets, so you provide incentives to actually improve care, to control costs, is a problem. Let me just give you an example. If you're an orthopedic surgeon, right, how do you make money? You make money by hip replacements and knee replacements. That's how you make money. And we know, or back surgery, right, putting in screws. We know that a large number of those people should not be operated on.
Exactly.
Right? So you have to create an incentive for a specialist to not do something. Capitation doesn't work well in that condition, and bundle payments actually can be problematic also in that condition. How you create that right incentive so that they have an incentive to not do what they do and still make enough money is a problem that we have not solved. Primary care, it's not such a big problem. So I'm not convinced by that because I think it creates a perverse incentive. If I'm an orthoped and I get paid per surgery, we know what you're going to do, especially when the guidelines for doing the surgery are not so clear-cut. You're just going to do more. You have to buy that second house. You need another car. You need a boat. So that's my reaction to it. You may not agree. That's fine.
So the problem is the specialists want always do more.
Yes.
Anytime. So if they are paid by action, they will just do more. And that is one of the problems in Switzerland. Nobody is really interested to reduce costs.
Yeah.
Neither the physicians, neither the insurance company, neither the pharmacy, of course. So there is really a problem how to pay them.
Well, so you have to pay them to do less. And so my solution to that problem is cost control. So you give them a budget for the people that they see, and you give them bonus for charging less for the people that they see.
A budget is almost capitation, no?
You may be closer than you think. I have another question about fragmentation and the solution you propose for the US. Why 6? For a minute there, I was asking myself, is there a principled reason why you want to have different healthcare insurance companies in your system? Is it a principled reason, or is it because you don't trust your own administration or your own corporations for a single payer system?
I think there is something called structural sclerosis. If you have only one organization doing it, there's an inhibition in innovation. There are, and we see this in lots and lots of places where you only have one. I mean, look, I'll give you one. The VA did a great job early on of creating a electronic health record, way ahead of everyone else. Now they're way behind. And it's true anytime you don't have some kind of competition. And so I think having 3 or 4 competing systems is very, very important to maintain innovation and to maintain a healthy way of trying to improve quality, improve access, et cetera. So honestly, I think having you can have a single payer that basically takes all the money, shakes it up. But I think a coordinator, especially for a system of 330 million people, having a single payer is not going to be easy. Just imagine the fights if you have one payer establishing all physician fees, right? We have enormous fights in the United States. You can't move. You have one payer for all doctors in the country. It's a bloodbath. Whereas I think if you have a different system where different payers can try some different things, you'll have some innovation.
I also asked this question out of the Swiss experience, where we do have some other things, not the health system notoriously, but some other things that are managed through private groups mandated by the federal government as a single thing, like public transport, for example, that has pretty good user satisfaction. And it's not like we have 6 different train companies, we just have the one, right? And it's in this mixed system that probably other countries have good experiences or bad experiences with as well.
Well, I mean, then first of all, it does rely on good public civil servants and high trust in the government. And that's also a public good where having multiple competing companies is not necessarily, for coordination reasons, optimal. But, almost every country, I don't know about Switzerland, leads to underinvestment and under-innovation. I do note that it took me 3 hours to get from Zurich to Geneva, and it wasn't a high-speed train.
We have geographic issues there too.
I don't know, it's pretty straight.
My name is Stéphanie Dacron. I'm a law professor in Geneva.
The lawyers are after me now.
Teaching social security law as well. Thank you very much for your presentation. I was wondering if you can tell us more about the involvement of the government or the governments. Health systems are not only financed through insurance. They are also financed, well, in most rich countries, they are financed through mixed systems with the states intervening. And I was wondering what is exactly the percentage or the amount, of intervention from the state budget.
In the United States or
in the US? Yeah. And my second question regarding reforms, I would like to know how likely it is.
Likely?
that
that's a
reforms
good. That's a very lawyerly question. So in the United States, approaching 50%, somewhere between 45 and 50% of all healthcare spending is by the state, the government.
And that represents how much from the GDP?
How much of the GDP? Well, 17.5%, it's something close to 9% of the GDP is government financed Medicare and Medicaid. You know, so about 140 million Americans are covered by the Medicare program is 60 million, and the Medicaid program is 80 million people. So it's a big amount, and they also have disproportionately sicker people because they have the elderly, they also have the poor, and people with disabilities are paid for by predominantly paid for by the government, and so they have sicker cohort than the employer-sponsored coverage. Employer-sponsored coverage pays more for the services they get. So if you look at health systems, you look at hospitals or doctors, they make most of their money and most of their profit, they'll tell you, from private insurance for the healthier group because they're able to charge them more. So that's how it goes. Now, I would say it is the case that lots of countries, Germany, Netherlands, even Norway, they do pool the money at the government, and then they pay sometimes intermediate organizations that then pay hospitals and doctors and organize it that way, right? Sickness funds in Germany and Netherlands. Here you have insurance companies. So it's that sort of cascading level. We regulate it, the centrals have a single payer kind of system, but the actual coordination with hospitals and doctors and payment system is done by private or quasi-private entities, is not an uncommon arrangement in the world. And I do think the bigger your country, the more complicated, the more that kind of intermediary manager is probably important, right? I mean, you have 9 million people, single payer systems that work well, they have 15 million people. Great Britain it's an interesting arrangement, right? They've got a single payer, but they've devolved now into hospital trusts because they needed some intermediate organizations to do. It's too complicated to manage a system for 60 million people. And I think part of what they suffer from many things, one of which is underinvestment, under innovation, underinvesting in new technologies and things like that because of the tax issue, because of lots of other issues. But they also suffer from, I think, trying to administer a system that is way too complicated for government bureaucracy. We all, we run our healthcare, our Medicare system, 5,000 people. You're spending $800 billion, and you've got 5,000 people running it. No corporation would be that lean, right? It creates lots of opportunities for waste, fraud, and abuse. How likely is it? Okay, it's a very good question. I left it out of this presentation because you don't want the inside. There is no chance, zero chance, that major comprehensive American healthcare reform is going to happen through Congress. Zero. And I'll tell you why. When the Democrats did the Affordable Care Act, they went on to lose 4 straight elections. 2010, 2012, 2014, and 2016 with the election of Donald Trump. Now, I don't know, anyone here related to a politician? Anyone here love a politician, right? My brother's a politician, okay? He was chief of staff for Obama. He was mayor of Chicago. He was a congressman. They're interested in one thing. One thing? Re-election. They're not going to vote for something that's going to lead to. Every politician knows about the Affordable Care Act leading to loss. Today, the population loves the Affordable Care Act. More than 60% of the public loves the Affordable Care Act. Okay? That's why there's no chance of repeal. No chance, zero. And why most Republicans are actually against the cuts Trump is going to make to Medicaid. So, the idea that Congress is going to vote for a health care bill where the positives are going to take 10 years to develop and they're going to lose elections in the interim, Zero chance. Okay, not happening. So how do you get something like this done in a democracy? And by the way, I don't think this is just a problem for the United States. I think it's a general problem of we've got old institutions and it's very hard to make them get transformative. I think the only way is a bypass the legislature. So the legislature has to empower a committee to come up with a solution, and then the legislature gets an up or down vote. But they can blame the other. So here's my example, made for a lawyer, okay? If you look at the United States, in 1776, we broke free. 1783, we made peace with the British. We came together under terrible constitution. Well, it wasn't a constitution, called the Articles of Confederation, a disastrous document. It basically was an agreement, maybe like Switzerland, of 13 different states, but each state had their own currency, each state had their own foreign policy, each state did whatever the hell they want, and they didn't agree to pay taxes unless all of them taxed. Terrible. And it was recognized to be bad because of a revolt in Massachusetts. So a bunch of 55 people, many of them prominent, came together and in Philadelphia in 1787, they were locked in a room during a hot summer. The windows were locked shut, no public communication, no media coverage, no cell phones, even then. And they, yes, thank you for the joke, they hammered out a constitution, okay? That's a constitution we have today. And it had to be voted up or down by each state. And when 9 voted it, it was binding. You could do the same thing, and we got our Federal Reserve, our banking system, the same way. You could do the same thing. We're going to find 25 people who know about the healthcare system from different perspectives, and we're going to take them to an island, a desert, Air Force Base, figure out where, and we're going to take away their cell phones. We're going to give them food, whatever they need, and they're going to come up with a system that we're going to vote up or down, and we're going to give them a timeline. They can have, I don't know, 3 months, 4 months, 5 months. They don't have to work out each detail, but they have to have a pretty comprehensive outline of the proposal. I think that's a way that we have gotten major transformation, and I think it's a way we're going to get major transformation because, first of all, most American politicians, and I've met a lot of them, don't understand the American healthcare system. There might be 2, 3 senators that actually understand out of 100. They say things, but they have no idea how to fix it. So relying on the legislature, who relies on other experts and don't spend the time to think about it, is a very bad solution. So that's my proposal. Some extra legislature to come up with the proposals that the legislature can vote up or down. Now, there are high costs to voting up, but there are also high costs to voting down because the system is bad. As the pressure from dissatisfaction increases, we're going to need a solution, and they are at a loss as to what that solution is.
I have one more rather different question that I would like to ask you, again, about what your current administration is doing. We're hearing quite concerning news about hospitals losing their sanctuary status and people being at risk of being picked up by the immigration police in emergency rooms. So first question, is it true?
No.
Second one, true or not, other people might be hearing that. Are you seeing people not coming for care?
Yeah, not true, and yes, it does create fear, and rumor, as we know from the internet, flies faster than truth. And so it's really, as you point out, largely irrelevant what the truth is.
If that's not the case, thanks again
Thank
so
you.
much.